Good morning, it's 8 o'clock. We will begin our echo clinic this morning on hypertension. Please chat your name in the chat box to record your attendance. We'll go around the room and introduce ourselves. I'm Shannon Switkowski, I'm the clinic coordinator.
Good morning, everyone. I'm Gautam Rao. I'm the director of the echo program as part of Cardi-OH.
Good morning, Jackson Wright. I'm also part of Cardi-OH.
Hi there, Jessie Lewis, project manager at CASE.
I'm Ian Nevar, I'm the director for Cardi-OH.
Hi, I'm Rick Panaccio, the web content producer for Cardi.
Excellent.
Okay, so I want to thank everyone for joining us again. I believe this is our 8th session, and I believe we had a fantastic session last week that unfortunately I had to miss with Dr. Bakris. So once again, after introductions, Shannon will ask you, of course, to chat your name and your institution in the chat box, just so that we have that information, of course. We're going to have our didactic presentations and 5 minutes of question and answers after that. We really do have to adhere quite strictly to that time. We do have 2 very interesting case studies today, which we'll go into immediately afterwards, and we will wrap up afterwards. And you'll get a reminder in your email, of course, to complete the post-clinic survey, which is extremely important. So I'm very excited about this specific session because it does deal with special populations who suffer disproportionately from hypertension. We have 2 great speakers this morning, Drs. Lawhorne and Dworkin. So I think we're just going to jump right into it if we can. Okay, Dr. Lawhorne?
So you can go ahead and go to the next slide. These are objectives for the elderly part. We're going to try to define elderly. We're going to look at how the management of hypertension has changed over time. And we're going to look at some of the current knowledge gaps. I'm going to give a couple of disclosures. One is that I'm a geriatrician and I take care of a lot of really old people. And the other is that I'm an old man with hypertension. So that may sort of set the stage for what I want to do. So the working definition of elderly is age 65 in this country. And basically, that's when pensions start, Social Security, medical benefits, those kinds of things. But operationally, it's really age plus life expectancy. So these are some of the factors that influence life expectancy, and I think these are pretty self-evident. Multimorbidity, polypharmacy in particular, people are always concerned about falls, activities of daily living dependencies. These are all things that we think about that may influence life expectancy. So this is a table that actually came out of the University of California, San Francisco a number of years ago. These are the same folks that do the e-prognosis, if you ever look at that website and that tool. So basically what it says is if you're fit and you're age 70 and you're a man, you may live another 18 years. And if you're frail and 95 years old, you may live another year. And so women live longer than men. We all know that. And in some ways, that's why my wife introduces me as her first husband. Let's go to the next slide. So is hypertension in old people an essential malady? In other words, you get old, you get hypertension, and that's that. Or is it a treatable condition? This is an interesting picture of Churchill, Franklin D. Roosevelt, and Stalin. And Roosevelt was known to have an elevated blood pressure in 1937, and his blood pressure at times was as high as 220 over 120. 2 months after this picture, he had a fatal stroke at age 63. And to me, he looks a bit older than 63 at this picture. And notice he's got a cigarette in his hand. So he was treated with phenobarbital, rest, low sodium diet, low fat diet. I think the rest part, he probably wasn't able to do all that well considering what was going on in the world at that time. But now it's gone to a treatable condition. So the first thing that got our attention, I think, was the multi-center VA cooperative study. And that really showed the importance of treating diastolic hypertension. And then the SHEP study, we started to look at systolic blood pressure elevation, and that was good. And then a whole bunch of studies since then, over the last 3 or 4 decades. We know that it decreases strokes, decreases myocardial infarctions and other cardiac endpoints, and increases survival. This slide and the next one is really just a brief summary of subjects, interventions, and outcomes, so that you can be able to look at those and get some sense of what was going on. I'm going to talk about each of them just briefly in a few minutes. So this makes it about a half a dozen of these studies in the past. So the SHEP study, the important takeaway, I think, is that remember that almost half of the people met their goal with low-dose chlorthalidone. And the other thing is the fourth bullet down, it benefited both men and women and all age groups. The systolic hypertension in Europe trial was interesting to us as geriatricians because of the third bullet, and that is that antihypertensive therapy lowered the incidence of dementia compared to placebo. And it was about 3.8 to 7.7 cases per 1,000 patient years. So that really got our attention. Next slide. Unfortunately, though, a more recent article, the Sprint Mind study, didn't really demonstrate that, but the authors were concerned that they didn't have as many dementia cases as they expected. So that one may be underpowered. So the Medical Research Council trial was interesting in that hydrochlorothiazide and a potassium-sparing diuretic was really quite good in terms of the cardiovascular endpoints. Atenolol, not quite so good. And so that's another reason to think about the utility of beta blockers in people over the age of 60. HIVET, same kind of thing. The authors suggested in that study that 150 over 80 was probably okay. Going any less than that for people over 80, they couldn't really talk about that based on their study. ALLHAT, a couple other things that came out of that, comparing chlorthalidone, lisinopril, and amlodipine. Takeaway for us, I think, taking care of older folks is that there was a little more congestive heart failure in the amlodipine group, and there was a non-significant trend to higher stroke rate in lisinopril. So our concerns about the randomized clinical trials for Sprint and HIVET particularly is that not so much multimorbidity, frailty, and polypharmacy as we usually see. And then some more concerns, Sprint subgroup, the older people in Sprint, they really had pretty good baseline function, not a lot of cardiovascular disease, not a lot of dementia, which of course we see a lot in their older patient practices. And even in HIVET, they were all over 80, but they didn't have much diabetes, didn't have much cardiovascular disease. So the recommendations from the American Geriatric Society, looking at all of these studies, including the 2017 recommendations, start with a thiazide or a thiazide-like diuretic or calcium channel blocker or an ACE or an ARB, but not together. For African Americans, we tend to use thiazide diuretics and calcium channel blockers over ACE inhibitors and ARBs. It looks like in the old that chlorthalidone still may be particularly effective in terms of looking at congestive failure, and be careful using alpha-1 blockers and central alpha-2 blockers. So here's what you've all been waiting for. What should the target blood pressure be? And I'm just going to tell you it should be somewhere between 130 over 80 or a little lower, and somewhere and 150 over 90 or a little lower. And I'm sorry that that's all you're taking away from this one. But it's so individualized that I think that's the important thing to think about. So the unanswered question is, are we meeting the needs of older people with cardiovascular disease in the health system that we have now? Next. This is a great article that I would, for anyone interested in treating cardiovascular disease in older adults, it's a couple of months ago in the Journal of the American Geriatric Society. These are some of the approaches from the workshop. American College of Cardiology, American Geriatric Society, and National Institutes on Aging. Look at the personalization factors when you're trying to come to your shared goals. Look at the role of precision medicine in the future, and really evaluate telemedicine and wearable sensors. So These are the steps in management that come out of this article, and I think they're really quite useful. They look at assessment, actions, and outcomes. The assessment, the patient goal, the shared goals, not your goal, not my goal, but the shared goal for the patients is very important. Looking at chronic conditions, how many are there, how significant are each of them, how do they interplay with each other, how do the medications that we give for them affect hypertension. Medication reconciliation, there's always an opportunity for that right at the beginning. And look at the person's adherence. What's it been in the past? So the actions, deprescribe, switch medications. We do a lot of switching from alpha-2 central blockers to something else. Look at the person's adherence to both the drugs and lifestyle interventions, and just monitor. And then the outcomes are listed there. And then we loop back and reassess and action and outcomes. So I think that's a great pathway for not only older adults, but for almost anyone with hypertension. So that's it for me, and I'm ready to turn it over to our esteemed colleague up in Toledo.
Sticking with our tough time scheduler, I'm actually going to ask Dr. Wright to comment just for about a minute or so, since he has a lot of experience and expertise in this area.
Yeah, outstanding presentation, Dr. Lawhorne. I was obviously very involved with both SPRINT as well as in ALLHAT. Will comment that even though with the compared to the use of chlorothalidone, amlodipine did cause more in the way of, was less protective in terms of preventing heart failure. It was overall cardiovascular events. It was just as effective as chlorothalidone in preventing all cardiovascular events, and was slightly more effective in preventing strokes. So that some trade-off for with heart failure, but better stroke protection with calcium channel block, and that's been shown in multiple meta-analyses. Lisinopril, the increased effect on stroke was probably blood pressure related, and it was mostly in the black cohort within ALLHAT, where there was a large blood pressure difference. And lastly, I think the evidence with treating hypertension in the elderly is fairly impressive in terms of preventing events now. The SPRINT-MIND, that trial was stopped early because of the fact that the cardiovascular events were so well protected in SPRINT, and so that did not go long enough in order to see the significant reduction in dementia, but mild cognitive impairment was significantly benefited. And also we have the MRI study that is about to be released, and that's been reported, and there was a significant reduction in at least a white matter lesions in the with aggressive, with less than 120. So that I think the evidence is very strong that treating hypertension in the elderly it benefits substantially with regards to certainly cardiovascular events, and increasingly now with protecting cognition.
Thank you, Jackson. Okay, so without any further delay, I'm going to turn things over to Dr. Dworkin, who can speak about special populations with respect to minorities.
Okay, thanks. So some of what I was going to talk about has been touched on already, but I'll try to pull it all together in the next couple of minutes as it relates to minorities. Could I have the first slide, please? So I just wanted to put up some selected epidemiologic data. There's so much information about the impact of hypertension. These are just a few facts I picked out. So it's the leading cause of death and disability worldwide. In the United States, it accounts for more cardiovascular deaths than any other modifiable risk factor. It's second only to diabetes as cause of end-stage renal disease in the United States. 25% of all adverse cardiovascular events are attributable to hypertension, and adverse cardiovascular events attributable to hypertension are higher in women than in men. And this is particularly relevant to what I'm talking about today. They're significantly higher in blacks than in whites. So here are a few things that I wanted to go over: the relative efficacy of different classes of medications in blacks and whites, and there is some data on that. Something about picking a target blood pressure, and do racial or ethnic considerations affect the most recent recommendation for a low blood pressure target, and then a little bit about how many medications are needed to achieve targets in minorities versus white people. So I'm going to review some of the same clinical trials, but from a different perspective. Really, I'm just going to talk about 3 clinical trials: ALLHAT, ASK, and SPRINT. And Dr. Wright was involved, I think, with all 3 of them, so he's the real expert. Obviously, all clinical trials have their pluses and minuses, and there's no such thing as a perfect clinical trial. So, and this is the recommendation from the ACC, AHA, and all the other alphabet groups on racial and ethnic differences in the treatment of hypertension. And really, they made 2 recommendations. The first one was that in Black adults with hypertension, but those without heart failure or chronic kidney disease, but including those with diabetes, and we'll come back to those exclusions. Antihypertensive therapy treatment should include a thiazide-type diuretic or calcium channel blocker, and I think what they're really suggesting is those are probably the 2 first on drugs. And then the second recommendation is that 2 or more antihypertensive medications are recommended, and they recommend a blood pressure less than 130/80. And I think these recommendations are consistent with the clinical trial data, and we'll go through that. So the recommendation, I think, regarding the relative efficacy of the different drugs comes largely from ALLHAT. ALLHAT was a very large trial with about 40,000 participants. Patients were high risk, and for cardiovascular disease, they were over 55. And ALLHAT was very effective in enrolling minorities, had about 35% blacks. So in the trial as it was originally designed, patients were randomized to one of 4 drugs. Doxazosin, that arm was stopped early because they had worse outcomes. So the study, in terms of the longer term, really compared the other 3 agents. So this is just some data on the relative efficacy of chlorthalidone, amlodipine, and lisinopril in blacks versus whites. And you can see that actually there were significant differences, particularly that lisinopril was less effective than either chlorthalidone and amlodipine, and this was already alluded to. So this is one of the pieces of information that I think has led to this recommendation. It's not that they're completely ineffective, but they probably have a lesser antihypertensive effect on average. And then not only was there a difference in blood pressure, but there were also some differences in outcomes. And so here are just a couple of outcomes that I pulled out. And so on the left panel here, where it's looking at stroke, this is the comparison between lisinopril and amlodipine. And what you can see about midway down the column there is that for blacks, amlodipine was significantly more effective than lisinopril in terms of preventing strokes. And as was already mentioned, this could be, in part just due to the difference in the blood pressure reduction, but you really can't tell whether that's it alone. And then on the right side is a comparison of the 3 drugs with regards to heart failure. And you can see that chlorthalidone was significantly more effective than either amlodipine or lisinopril in preventing heart failure events. And, you know, this kind of runs counter to the usual thinking, which is that ACE inhibitors or renin-angiotensin blocking drugs are particularly useful for heart failure. This doesn't mean that they're not useful. It just means that the amlodipine was more effective. But I think if you put this all together, less efficacy in terms of absolute blood pressure reduction, less of a protective effect against stroke than the amlodipine, less of a protective effect against heart failure compared to chlorthalidone. That's largely where that recommendation, where that's a lower option for initial treatment of hypertension in African Americans has come from. And, you know, it's pretty well supported, I think, by these data. So there's a little bit of a different story when it comes to chronic kidney disease. And the study that has looked specifically at the impact of different classes of antihypertensives on progression of chronic kidney disease in African Americans. It was the ASK trial. That was a study in about 1,000 African American hypertensives, all of whom had some degree of underlying renal disease. And it was both a blood pressure tight versus less tight control and a drug trial. And I'm only going to talk about the drug part of this. Actually, in this particular trial, the low blood pressure target didn't have much of an impact. But here you can see for the group that had some degree of proteinuria, a comparison between ramipril, a beta blocker, and amlodipine. And amlodipine actually did less well than the other 2 drugs. And actually that arm was stopped prematurely in this trial. But the final conclusion from this trial was that for African Americans with renal disease, if they were proteinuric, that ACE inhibitors were important drugs to provide. And I think that's where you get this sort of exception for patients with chronic kidney disease, that ACE inhibitors may be useful in that group. So the last trial I want to talk about is SPRINT. And SPRINT was a large trial, as most of you know, with about 9,000 patients. They were over 50. You only needed to have a systolic blood pressure of 130 or greater, whether treated or not treated, to get in. And although it wasn't designed specifically to look at comparisons among the different racial and ethnic background people that entered, they did enroll, again, significant numbers of minority patients. You can see here close to 3,000 Blacks and about 1,000 Hispanics. So the main point of SPRINT was to compare the 2 blood pressure targets. It's important for this study that there were no diabetics. That's because a previous trial, ACCORD, had really done a very similar design in the diabetic population. This study did try to over-enroll elderly patients and people with chronic kidney disease, and didn't really quite meet targets, as we've heard already, in terms of those subgroups. So in terms of the actual impact on our ability to reach the blood pressure trial, the low blood pressure target, actually they did well in all of the different racial and ethnic groups. So you can see this is Blacks, whites, and Hispanics. All 3 groups did comparatively well in achieving a separation between the 2 blood pressure targets. The one notable thing, and this comes up in the recommendations again, is that on average, it took a little bit more medication to reach the low blood pressure target in the Black. And that's been confirmed in other sets of data. So this is a study that, or it's a compilation of data from a lot of different clinical trials, including SPRINT and ASK and ALLHAT, but it shows the number of blood pressure medications needed to achieve targets depending on comorbidities. And you can see that on average, it's about 2 drugs. And in some of these studies, the target was not that low. But if you add on diabetes or hypertension, and then if you add on African American on top of that, it oftentimes gets up to 3 or 4 drugs. So just to wrap it up, this is the way I would sort of summarize the data. So I think in terms of picking the drugs, the truth is that many factors, including patient preference, age, comorbidities, racial, ethnic background, and lifestyle should be considered when you're picking a blood pressure medication. So I think these recommendations about particular drugs, they should be considered, but not necessarily rigidly adhered to. Thiazide diuretics or calcium channel blockers are reasonable first-line agents for Black adults with uncomplicated hypertension. But if you're a patient, if you have a patient with diabetes, chronic kidney disease, and proteinuria or congestive heart failure, an ACE or an ARB should be also considered a first-line therapy. Depending on comorbidities, 2 to 4 medications will likely be needed to achieve the recommended target of less than 130/80 in minority patients. And then particularly in African Americans and also in women, I think it's important to remember that when you're using renin-angiotensin blocking drugs, particularly ACE inhibitors, that they have an increased risk of angioedema, and you need to be alert for that. So that's my last slide.
Okay, thank you, Dr. Dworkin. Just a couple summary items. Dr. Aurora and Dr. Lawhorne had an interaction on the chat that dealt with clonidine. I just wanted to summarize that. And it's something I've noticed as well, Kriti, is that some of our elderly patients are on clonidine. Who knows why? It might have been started at menopause and they've been on it for years and years. But Dr. Lawhorne suggested that it's generally best to taper it to stop the clonidine due to its significant side effects, which sounds perfectly reasonable to me as well. And a question from Sue Paul, would love your thoughts on a 96-year-old. This is actually a good question, who is very active, drives, is still on a statin, had a stroke, has dyslipidemia, and some other conditions I can't really make out very well here. But would you continue the statin or not? Of course, not a hypertension question. Personally, if they're not having any side effects, any myalgias, depending on the dose of the statin, I suppose you could continue. Any thoughts, Jackson?
I would actually like to hear Dr. Lawhorne's comments on that.
I know from the obesity standpoint, we pretty much would have stopped treating, addressing that issue long before that age. So.
Yeah, but at 96, depending upon an active 96-year-old.
I'll make a comment about that.
Sure, Larry, go ahead.
It really still becomes a shared decision, I think, in a lot of ways. I don't know that the jury's in on what we should do about the statin. It looks like this is a person who's done a lot of things to take care of himself or herself over the years, and they would probably want to continue a statin, and I would be fine with that. We generally send, if we're concerned about driving, we generally have people evaluated by occupational therapy. They do a really good job of evaluating a person's driving skills. So I would, this is a person at 96 that I would still be pretty aggressive with, because it looks like that's what they've done over the years.
Thank you, Larry. So I just had a question for Adam, who just wanted his perspective on some of these patients. So Dr. Dworkin was talking about sometimes 3-4 medications are needed to control blood pressure in some minority patients. And I have that phenomenon as well. Most of my patients are African American. Many of them are elderly. and they're on 3 or 4 medications. And I wonder to what extent that's a physiologic effect, and what extent that they are just picking and choosing the medications they feel they want to take, which seems to be a phenomenon as well. And it may be due to cost or access issues or simply preference. And see if Adam had any thoughts about that.
Well, I mean, certainly we know that, some folks take only some of their medicines. One of my favorite approaches to this comes from a Metro Health geriatrician, Dr. Jim Campbell. And his approach to that conversation with patients is, one sense is it's really an individualized thing. It's hard to say that for a group of individuals that there's some common behavior. So his approach is to sort of disarm the situation by saying, look, everybody doesn't take some of their medicines sometimes. Which of these medicines are you actually taking, right? So sort of taking the shame out of the fact of that in that interaction, where somebody might not feel fully comfortable, or maybe that relationship isn't like perfect, and they're willing to disclose by saying, by being humble and saying, look, I may miss some of my medicine too. Which ones are you missing, as a way of addressing that personally with the patient? Because folks have to integrate this pattern of taking medicine that can be very complex into their personal biography, and really accept that it's part of who they are before they're gonna adhere to it. And different folks have different levels of acceptance of doing that at different stages.
Okay. Thanks for your comments, Adam. Conference on May 17th with our keynote presentation by Dr. Brewer entitled Inspiring and Empower Communities to Improve Cardiovascular Health, obviously highly relevant to what we're doing here. And I'm going to turn things back to Shannon.
Thanks. Just a reminder that there are SAME credits available for this session, this clinic, and there will be a survey emailed to you to complete by 5 p.m. tomorrow. And next week, we will have Dr. Luke Laffin from the Cleveland Clinic, Case Western Reserve University site on the integrated approach to cardiovascular risk management. So we'll see you all next week. Have a great day.
Thanks, everyone.